EMS Underground. We're going to do this again because we learned something about streaming is that you can't let it buffer.
Take two.
Yeah, there you go. I am Charles McFall.
Tom Campling.
And again, I'm going to pull it up on my phone. But today we're talking about shortcuts, the good, the bad, and the ugly, the things that people do in EMS, do in learning, do in life. And let's start with the good shortcut, Tom. And, we're right on it now. Yeah, good. So I'm going to share this again. One of the good shortcuts is, of course, the pocketbook you can carry. Nurses have them. ACLS has them.
Doctors have them.
PLS has it. Or PALS. PALS has it, rather. Mm-hmm. PLS is just short for please. I don't know why they'd have a book. I can't tell you that. So, but you said, what if you leave it at home? Well, that's the nature of a shortcut, right? It's a crutch.
If you leave it at home or you lose it unseen. And you know what? When you lay it down, people like those things. So
they do. Yeah. They pick them up. I can't tell you how many books I've lost and how many books I've acquired that way as well.
Because they just sit there, and you don't know whose they are. I mean, you're not going to leave it there.
Right. Well, even if you do know whose it is, I mean, some people are going to pick it up and put it in their pocket anyway. Right. It's one of those things.
But it's also a good tool to have, especially at 3 o'clock in the morning. It's hard to discourage it. Remember, another shortcut is your protocol manual on the truck, and these are things you got to check all the time.
It helps to memorize them.
Mm-hmm.
Definitely know your protocols, those kind of things. Now, as we get started, we're still getting warmed up. We want your feedback, your ideas. This is live on Facebook, so if you make a comment here in the Facebook stream, we will see it. We'll answer it. But the whole concept is definitely shortcuts. What are some other good shortcuts? So do you, when you were an active medic, did you actively walk on the scene and think, okay, scene safety, and look around for a whole 30 seconds, and then PPE, and then make sure, you didn't slowly do those steps, did you?
No.
You kind of did it all at once.
All at one time.
Right.
It's all automatic, really fast. And you don't even think about it. You just do it.
Mm-hmm.
When you're a student in school, you're thinking about every step. Oh, my gosh, I'm going to miss a step. I'm going to miss points. But in real life, you are actually doing all these steps at one time as an integrated skill. Right.
It's because your brain works on so many levels, right? You're walking in and you're noticing what's going on around you as you're putting on your gloves. If you didn't put them on in the truck, because a lot of times the passenger will start putting them on before you get there. The driver will grab the stuff, whatever. What else? What is something that you did as a shortcut you thought was okay?
I would pre-package sometimes my own IV kits or have things set up like shortcuts around the truck, in the back of the truck, like for airway management. I had my airway management stuff set up in one spot for that instance. When I started as a flight medic, I used to take Ziploc bags, and I would take like an INT cap for an IV, a 20 gauge and an 18 gauge, a roll of tape and a tegaderm, and a small thing of saline, and put in a bag, and then I would keep it with me, and all I have to do is pull it out. And I sometimes even have a extra pair of gloves in there. So all I do is pull it out, and I've got my gloves, my tape, my tegaderm, my IV stuff there.
All ready to go.
All ready to go.
A little kit,
instead of having to put it together and go through everything, I know everything's in there.
So instead of doing a Batman utility belt, you did, Mama's utility belt with the Ziploc bag.
Ziploc bags. Put them in there, keep them clean. I guess another shortcut, too, is that's good is, remember, now, the guys out there today who are doing this, they don't worry about it as much as we used to. Remember the map books, Charles?
Yeah. I got a story about map books.
And taking a highlighter, but you still, if you don't have a map book on your truck, you need one. Everybody needs to know how to use a map book, because when that GPS fails.
GPS can fail. You can lose your cell signal. True GPS works off of a straight GPS signal, but the cell phone GPSs work off of both a GPS signal, but it's not, I don't think it's a true GPS signal. I think you have to have cell service, because I know a lot of times I use Waze, and I know the map will come up, and it'll say, look, you're searching for service. And it'll give me a memorized map of when it's downloaded. So it knows where I live. It knows the state of Georgia. It has a basic map program, and it might get me from point A to point B. But if I don't connect to a network, it won't find traffic stuff. It won't guide me around issues. It's got a lot of problems with it. So map books are a great fallback.
Yeah.
I mean, there's rural areas that just have no signal.
There's nothing. And then what about on a bad cloudy day? You're sitting there
Right.
waiting, or if it's really stormy outside, it's waiting, or you drop the thing and it breaks.
Yeah, there's that.
And then you've got your map book. And I remember a shortcut we used to do. Remember when we got the new editions of the map books? You sit down and you highlight the streets in your territory with a highlighter.
Sure.
So that whenever you're looking for a street, you're only seeing the ones that are in your territory.
Yeah.
Remember the highlighters?
Kind
Highlight
of.
it.
I remember I was working for National EMS, and they had a big black folder book with all laminated pages in it, and I can't remember exactly how you cross-reference the sheet. Maybe there was a thing in the back. This is when it was in Morgan County, so it's rural and lots of dirt roads and big space to cover for 2 trucks. And I think there's a glossary or index or something in the back that you say, okay, you knew such and such road, good road. Mm-hmm. And it's a page 56, D9, I5, whatever. And you'd flip to that page and you'd find the road, and then you'd have to find your cross street. Mm-hmm. And so actually, while I was in Morgan County, we had the same kind of book. And there's this one section in the north end of Rockdale County. I think I said Morgan County, but I meant Rockdale County. I was in Conyers. And there's just this one access road that's kind of out there on the edge of the county. And there's a couple ways to get it. But if you don't come in the right way, you'll spend extra amount of time going to where you're going. And this was in the days, I talked about this before, but I had to be the best and I had to be the fastest. And my partner was driving. I'm looking up the thing. We actually have a third rider who starts panicking for some reason. I don't know why she panicked. It was nothing to it. But this is before GPS really, I mean, it was out, but it was expensive to get, and trucks didn't want to do it, those kind of things. And actually, some of the flight crews had talked about, as a company, the flight company would invest to give all EMS crews GPS locators, at least. So you could tell when you're ready for a helicopter, you could say these are the coordinates and those kind of things.
Right.
I don't know if it didn't happen, but that was a good idea. Anyway, so I'm flipping through the pages. I'm trying to find it, and I'm telling my partner to go here. And it's at night, and it was supposed to be a chest pain thing. And God bless the fire crew that I ran with, because it wasn't the crew we were in house with. It was a different crew, but they all in our territory, so we all worked together all the time. And they got on scene, and this chest pain call that should have taken 5 to 7 minutes to get there, 45 minutes it took me to get there because we couldn't get the map book to line up right. We'd get to the end of the page, go to the page it said to go to, and we could not recognize where it was. It was a little bit of a mess. And luckily the crew downgraded us, said, they went through the steps, and so we didn't get any trouble. But I was very mad at myself and the book, and we did lots of territory studies after that, because map books are a shortcut. But if you know your area, I mean, it's a good shortcut, right? But if you know your area, that's even better. I loved riding with BK because he was also a police officer here in Newton County, and he knew every road because all he ever did in the cruiser was territory. Or Shirley, yeah.
Or Charles.
I didn't ride with Charles too much.
Yeah, they know.
But they knew all the roads, so I wouldn't even think about it. But that hurt me because when I rode with Mike or James or somebody else, they were about the same as I was. We kind of knew the areas. Like, well, crap, I guess I should learn more.
Get out and learn the area. Another shortcut, I think, that can go either way, can be good or bad, is your clocks for administering drugs.
Okay.
Sometimes that can be, can hurt. Sometimes it can help. Especially if you know it, because if you're off a little bit, it could be detrimental for the patient. Yeah. And then what's your defense when you're in court? I remember using the clock, or I was using this. So if you're going to know it, make sure you know it really well. But I think you really need to memorize and know your basic drug dose calculations so that if it doesn't look right, you can fall back and make sure. Always check and double check. I used to always check with my partner and check and see.
Yes. That is something I've learned in life, and I've just jumped in as I'm adding something to the Facebook group here. But we are taking questions. If you have any about shortcuts, we're going to get into the bad and the ugly ones here shortly. But that's the theme of today.
Get to some bad habits.
Some bad habits. We will.
Oh,
we will.
Yeah, we're going to get there.
But to finish up the good habit or the good shortcuts is the idea that you have to defend it in court, right? Everything on the EMS,
especially when it goes wrong, because you have so many times. And how the shortcuts end up biting you is that you're going along, and it worked this time,
right?
Or did it work?
Right.
You just didn't get caught.
Maybe.
And you didn't have an adverse
or you
reaction.
Lucked out.
Because, it's like, I have a saying in EMS. Rule number 1, people die.
True.
Rule number 2, we can't always change rule number 1.
Okay.
Rule number 3, we should always try our best to change rule number 1 when ethically, when it's ethically and right to do so, right?
Okay.
However, sometimes despite your best efforts, the patient still lives.
This is true.
So, but also too, sometimes despite your best efforts, they still die.
This is
you
also
can do
true.
everything perfect, and the patient still does not have a favorable outcome.
Right.
But the same thing can go. You use shortcuts or you do shortcomings, and despite you doing that, the patient still it doesn't affect them that much. For instance, back in the old days, the thing is about dopamine. Turn it on until their ears turn red, right?
I don't think I learned that one, but yeah.
So you do that, and 20 times nothing happens. Positive,
right.
Hey, they saved or whatever. But the 21st time, it goes wrong, and how are you going to defend that?
And the same with nitro. You're supposed to have a line before you give any kind of nitroglycerin pills or anything. But I know people who will take these tabs while you're still setting everything up. And you're right, it can have an adverse reaction.
Well, they've changed that now. You've been out of it for a little bit.
I have.
Yeah.
I have. What do they do? What is it now?
You got Basics giving nitro.
Okay, but Basics can do a line.
No.
Okay, how does that make sense? Wait a minute. You can't start a line, but you can give nitro, which will drop your blood pressure. What?
Yeah.
That doesn't make sense.
Yeah, Basics can give patient assist if a patient is.
I didn't think Georgia had a basic anymore. I thought it was always intermediate.
No,
and then they added advanced.
See, what we used to call basics, Charles, back in the day, what we used to call a basic was an intermediate everywhere else in the country.
Okay. Well, that was our bottom. Georgia was intermediate. That was the bottom level you could get in on.
Now in Georgia, you got to realize we have how many levels do we have out there, y'all? We have EMT. We have intermediate EMT.
Okay.
We have advanced EMT. We have a cardiac technician, and we have a paramedic.
All right.
Oh yeah, wait. Let me start. I forgot about first responder. So we got 6 levels. Okay. So we got first responder, EMT, intermediate EMT, advanced EMT, cardiac technicians, and paramedics. So we have 6 levels out there now. And now is the EMT basic. Even EMT basic now can give Narcan.
Okay, but Narcan really doesn't have a negative effect. Well, I mean, if you're really into the drug, it can kill you. But other than that, that's not really Narcan's fault.
And I'm all for that because we're training
But
police
so
officers
basic can't do a line, but then give nitro tablets.
Yeah.
I guess did they find that there's not enough dose in 2 tablets to drop it enough?
I think what they found is when they drilled it in us for so long about you got to have a line, you got to have a line.
Right.
What they found is that hey, we've been giving nitro to these old folks to use at home on their own.
They don't have a line,
and they don't have a line. So why can't EMT do it?
I guess, but that does go against everything I was taught.
It goes against what all of us were taught, but not nowadays. Right. Which good, bad. Anybody got any comments out there on that?
Well, we do have a question, but not on this. But Chelsea, we will answer this question at the end of the show because right now we're staying on the theme of bad habits, good habits, and the ugly habits. And I think people want us to talk about bad habits, but that is a great question, and I do want to answer that before we end this show. But definitely stick around. We're going to get to that. Bad habits, man. And this is not just on the truck. I mean, life, bad habits.
About driving.
Learning, all that stuff.
Bad habits of driving.
Oh, man. Yeah, not being prepared to stop at an intersection when you're going license sirens it's an easy habit.
Even though I think the law says we can text in an emergency vehicle, but if you're driving and your partner's next to you, you really need to be paying attention to driving.
I've slapped the partner for that.
It's and I think a lot of times, a lot of our injuries that happen to us is when we're in the back of the truck.
Yeah.
I know. I the only time I've really halfway fractured a bone in my body is when I was in the back of the truck and got thrown forward because
they had to slam on the brakes.
So
that will get you. I know one of the bad habits that really, really kills me is it's a punishment habit. Really, it's not a shortcut. And shortcuts are habits, right? So it's actually a long way around. It's the opposite of a shortcut. But I've known medics that any call after midnight. I give them a line. They're getting a 16 gauge or a 14 gauge. I'm like, why? Why are you punishing them for? Yeah, I mean it might be, oh, my stomach hurts, I want drugs. It might be a BS call, but why are you wasting your time and energy to stab somebody with a 16 gauge?
And is it going to do any good at the end? I don't think it's going to do any good at all. Except for make things worse for you if something goes wrong.
Right. A question Julie has is, do we have any RN paramedics in Georgia?
Yeah.
Do we?
Yeah, but there's two separate licenses. Usually on the helicopter, you've got a lot of dual licensed RN paramedics that do it. But some aren't paramedics, but they are. I know quite a bit of people, quite a bit of RN paramedics. Jason Hale, RN paramedic. Rob Andrews, RN paramedic.
Rob. Yeah, that makes sense.
Rob. And a lot of them that fly also have their RN. It's two separate things. It's like apples and oranges. Even though we do both provide patient care, we do it under two totally different environments.
Right.
And it's kind of hard to compare. On the helicopter, we always flew nurse medic. There's always at least a nurse and at least a medic on the truck on there. Now, sometimes you'd have a person who was an RN and a paramedic, and then you'd have an RN, or you'd have an RN paramedic and a paramedic, but you at least had that one of those certifications on there because whenever you do interfacility transfer, it gets very complicated, and that's where the nurse takes the lead. Well, on the scenes, it can be complicated as well, and that's where the medic takes usually the lead.
No, I get that. I've ridden with there was a few high-end transports I had to do that dealt mostly with pediatrics, and is a very special transport box for the baby, and a pediatric nurse came with me, and we talked ahead of time what the plan would be. If this happens, this is my world, and I will do everything I can. But you're the expert, so you have to have that partnership. So that's how that goes. But and again, if you like anything we're doing, hit the thumbs up. There's a heart button on the live one. You can send us hearts because this is a new medium, so I'm teaching you how to use it. We want to see those hearts come flying across, so we know you like what we're doing, and if you're entertained and those kind of things. And of course, keep your questions coming. But we're talking about shortcuts, the good, the bad, and the ugly. What's a really bad shortcut on the truck that you've seen? That's almost an accepted look the other way standard.
Really bad is passing up basic airway maneuvers for advanced.
Oh yeah, I did that all the time.
Yeah, just flying right past it. Patients laying there needing to be ventilated adequately, and they're not. Man,
I had some. See, that's where I always relied on the EMTs myself. Was like, okay, it's basic airway. I've got to be setting up my gear. And we always go with the bag valve mask, right? You lift the jaw, you're breathing for them, chest rise. And I would always wait. And I only had one or two go-getters that would put in the oral airway first and then do the bag valve mask. And I always commended them on it, but I never required it because I moved fast enough, and I felt like, and I could have been wrong. See, that's the thing. It's all about our perception, right? We think we're doing the right thing and everything's working. But I felt like the air was getting in appropriately, and I got my tube usually within 45 seconds of getting everything set up. It doesn't take that long.
I think another one.
I've never put in a basic airway ever, except in class.
I think another one is overventilating, not paying attention.
Oh yeah, yeah,
You know?
yep.
And that's one that the American Heart Association, the NAEMT and PHTLS and all that have started really coming down on, that we have been overventilating patients. Hyperventilation's not always good. We want to make sure that we adequately oxygenate,
Right.
not so much hyperventilate them, because the hyperventilation is being shown to do more damage
Okay.
than good. Look at CPR. Now, remember back in the day,
15 and 2 is what I had.
and we had to get that airway.
Yeah.
Stop.
Yeah.
Everybody stop. Got to get the airway.
Well, it's kind of hard to hit the hole when it's going up and down.
but
you know?
but no, I mean, how long would they sit there and no compressions going?
It could be maybe even a literal minute. A figurative minute.
So now we've got other airway devices, combi tubes,
Right.
King Airways that you just pop in there, and the research is showing that, hey, this may be better. That's not to downplay the endotracheal tube either, because I think it has its place. Every one of these has their place.
Right.
That there should be.
Right. And I was honestly, I kind of overdo everything that I do, and I rarely lost a tube because I probably shoved it so far down their throat it wasn't even funny. It was once I got the tube, I really went in, just kind of past. There's always a teeth mark, right? I always went past it. I just didn't trust people. I had so many bad medics. Well, not bad. Okay, rushing. People were rushing to move the patient, this and that they let the head go back. And then, of course, if the head goes back, there's a good chance you're going to lose your tube. And it's like,
All right.
you know how difficult that was to get in the first place? And so I would overdo it for sure. But this being a school, one of the things I wanted to talk about was the things that we see with bad habits is, like we talked about with the relying on the map books, not actually learning your territory, not actually learning how to do the steps, or not taking care to do the steps. And one of the things that I've done, now I'm a very fast learner, and I can do things very easily. And I did ACLS online the last time I restarted it, which was years ago. And the way they did it online there was a video, and it was timed. I could not fast forward. I couldn't do anything. And so I'd let the video play, and I'd be on another screen doing things, and then go back to it. As for me, though, as long as I can answer the questions and pass the test, and I don't mean just barely, I mean I feel confident in my information, you're boring the crap out of me because you're teaching to a general broad audience. Now, Tom, here at Georgia EMS, or Georgia Institute of EMS, you do log instruction online, but you didn't put in a timer, and you're finding that there were people who were opening up all the videos at once,
Right.
and then failing the test, and that is a horrible shortcut.
It is. And one thing I just want to emphasize is that depending on what shortcut you take, you cannot shortcut the end product. The end product is going to be reflection of what you actually, of the time that you actually put into the course.
Right.
If you don't put the time into the course, it's going to reflect on that exam whenever you take the National Registry, either the practical exam or the cognitive exam. So, for instance, I tell people all the time, if whenever you're reading the book and it says the signs and symptoms of congestive heart failure are, what should be going off in your mind is ding, 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 I need to memorize these. Unfortunately,
Right.
there's no shortcut
Right.
for everything, and you can't shortcut not knowing the signs and symptoms, the foundational signs and symptoms of all the main conditions that we have to be able to treat and recognize at a moment's notice. For instance, like myocardial infarction or a heart attack, we don't have a lot of time to be sitting there going through a flip book and saying, hey, he's diaphoretic. Yeah. Oh, by the way, I got to look up what diaphoretic is, or, because what is this symptom? No, you need to know that. You need to know the signs and symptoms of a myocardial infarction. You need to know the difference between myocardial infarction and congestive heart failure. The difference between COPD, asthma, and pneumonia. Yeah. And CHF, and so on. and it takes time putting it in. Once you get a foundation in place and you have a solid, strong foundation, I think then you can start developing some shortcuts that will help bridge and make things faster for you. Some good shortcuts that I really like teaching are the mnemonics.
Okay.
Decap BTLS, Pearl, TRD.
DRT.
Yeah. TRD, and I say turd because you find it in your abdomen, tenderness, rigidity, distension.
Or the other way is DRT, which is dead right there.
Yeah. Right LBDF, looks bad, dry fast.
Yeah. And while we do this, I know not everybody watching is in the world of EMS, and we throw out a lot of acronyms. Sometimes we'll explain them. And in this case, this is just an example. We don't need to explain what all of those are. I had a habit of being when I was in a very busy territory. I don't get up very well, like in the middle of the night. I mean, I do jump up, I wake up, I move kind of slower. I think maybe we all do, but I definitely felt like I moved slower. So I'd sleep in 70% of my uniform. I never took my uniform pants off. This is when I worked for National EMS, so we had the big polyester shirts. I didn't want to sleep in that. So I'd take the uniform shirt off and my boots to be at the end of the bed. The tones would drop. I would jump up, slide to the end of the bed, put my feet in my boots, then grab my shirt, and I'm tucking it in as we're going to the truck, and that works. But as far as the learning habits, so this actually plays in. So somebody asked, theory or lecture versus actual real practice, advice to new grads. Advice it's everything is theory, man, until you put your hands on it, right?
Yeah.
And you start figuring out a flow. I mean, that's probably the best way for me to put it is a flow to it. You'll learn efficient ways to do things versus the actual by the book, here's how you do everything step by step. But you'll learn some bad stuff as well. But you have to learn. I mean, that kills me. It always killed me to have somebody on my truck who didn't want to learn their territory. Who did? I mean, when you told me about people opening videos, just in general, like, yeah, this has happened in the past. I'm like, are you kidding me? You're paying to come to school to learn something. You can't shortcut a test. I mean, you just can't. Now, if you know it, again, I'll give you the caveat. If you come from another state and you have to go through the course, or you come out of the military and you have to learn, there's certain things you need to pick up on for the state of Georgia that are different than anywhere else. But you already know how to start an IV and all the safety procedures. You know how to do compressions and blah, blah, blah. I'll give you that. I mean, I'm there. If I know it, I just kind of want to, the old TiVo, bloop, bloop, bloop. Let's get to the next thing. But if you don't know it, why would you rob yourself of that experience? And that's my advice to new grads. Don't let old burned out guys and gals teach you bad habits because they've done it for 20 years. And maybe it's good, but go with what feels right and stay safe. You'll learn the ins and outs.
Well, at the end of the day, what you're going to be judged against when you go to court is what's in that textbook. Yeah. Because it doesn't matter. You can have, who do you want defending you? Do you want a 15-year-old medic 15-year medic who's been doing it the wrong way for 12 and a half years or 13 years?
Right.
Or do you want the medical doctorate that has not only an MD but a PhD? He was a paramedic, went to med school, he got his MD, he went ahead and got his PhD so he could get into teaching. He got in there, wrote a book, he did research after research after research, tours the country teaching this stuff. Who do you want sitting on the that witness in that witness box against you?
Thing, yeah.
Do you want him for you or do you want him against you?
Right. You're right.
I think I would go for the guy that has all the credentials because think about who are you going to side with. Now, there are some things out there, and let's say the question is about theory or lecture versus actual or real practice. Yeah, you got to get the foundation. And that's what we do here in school. That's what you do when you're in school. You get the foundation. It's like reading. Whenever you were in school in primary school and you learned to read, do you read that exact same way that you did back then? you learned your
If I'm
own
drunk.
way. If you learned your own way, eventually,
Right,
you learned
right.
your own way, and you're able to do it. Now you do it your way. And that's the same thing here. You'll learn a foundation. Like, this is the foundational skill. This is where this is the standard. And then when you get out in the field, you kind of learn, hey, this is the way I do my assessment. This
Right.
is the way I write my report. As long as it's all in there, we get this. Now, a complaint that I get all the time from students is that this instructor taught it this way.
Mm-hmm.
But this instructor taught it this way, the same skill.
And it's all correct.
And and they're like, well, which way do we do it? Which way do you want to do it?
Right.
We're here to
You're
give you...
You're talking about Common Core EMS.
Yeah, Common Core. Like...
I know it's a controversial thing in school with math and all that.
Like, if Jim has 50 candy bars and ate 49, what does he have?
Diabetes. Yeah.
So you take the backboard, for example.
Yeah. Okay.
There are different ways to do it. So we need to give you as many tools. Think about this. What you learn in school is almost like a tool that you put in a toolbox, and you're going to take it with you to work.
Sure.
So we're wanting to give you as many tools as we can to put in your toolbox, because whenever you are on the side of the road, that overturned vehicle, and it's thundering and lightning, there's tornado sirens going off, there's 18-wheelers going next to you, visibility is like less than a quarter mile, hail is hitting you in the back of the head,
Right.
and mud is rushing all around you, you need as many tools as you can have so that you can get that person out of that car, because there's no one way to do it.
True.
In as many ways as we teach you, we only can teach you the foundation here. And once you get out in the field, you're going to have to figure it out by using
Right.
the tools that we put in that toolbox. And sometimes you got to take two tools and use two tools at one time to make one procedure. Mm-hmm. That's why the National Registry gives you a question and then gives you 4 wrong answers. And you got to choose the one that is the least wrong. Or they give you 4 correct answers, and you got to find the one that is most correct. Right. Because you've got to be able to put everything together, and you've got to be able to formulate something new that is just now being presented to you for the first time. Because that guy that wrote that book, he's not there.
Right.
But we've got to give you the tools so that when you are there, you can take, hey, whenever Tom taught the class out in the parking lot, he showed us this. But when Steve taught us the class out on the stairwell, he taught us this. Well, they're kind of in both situations here. So here, let me try this. And now I can put one skill together that gets them out and keeps them with the
along
best
those lines,
outcome.
and leading into this next question that just popped up, there's times when, man, you'll have, I can't remember a time I've had an official instructor say this to me, but I've heard it happen. I've definitely had paramedic captains, and I've had trainers on trucks tell me this. Don't do it this way. Just close your eyes for a second. It's like, but you're the trainer, you're the lead, the inspiration, and you're doing it wrong. And you're telling me not to do it your way, but what am I going to do? I'm going to absorb that. And to wrap up what you're saying about going to court. Now, here's the thing with medicine. Well, at least from our standpoint with the emergency medicine, is every action you take and every document you write. So we're actually talking about from a good standpoint of your actions have to be right, but in reality, it's not your actions that have to be right. It's your report that has to be right. And the thing is, I mean, now with the advent of cameras in the back of trucks, you've got witnesses, you've got people who believe they're doing the right thing. Just because you write a report one way doesn't mean it's going to play out in court that way, but you have to do everything ultimately in 2 veins. One, to save somebody's life, or to give the medicine that's needed, and to, if this goes to court because something went wrong or somebody blah, 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 how do I defend this? And I don't point to you just for the sake of example, your 40-year veteran burned out medic won't be there to get your back. Well, no. my medic Tom said this, but weren't you taught this, and this? Well, yeah, but doesn't matter. Tom might have your back on the truck. And not that Tom actually would do it. It's a second example, right? But Tom might have your back on the truck, but he's not in court. Maybe they cut him a deal. Maybe they're hitting you both separately. Whatever. They pit you against each other. Aruba. Maybe he died, before the court case came around. Because I was off the truck 7 years before I got my first lawyer to ever call me. I didn't have to go to court. It happened here in Newton County, actually, and you were involved. But I think you were involved. I think it was a shift. No, it wasn't. It had nothing to do with us specifically as a first responder thing and this and that. But I told him, I said, dude, it's been 7 years. My report's my report. And here's what's going to happen. You call me to court, because he was trying to sue and do this stupid stuff. And I was like, here's what's going to happen if you call me to court. I'm going to read my report. I'm going to tell you verbatim what I said on the report. And then that case had been actually before the 7 years that had been off the truck. So I was like, what am I supposed to do? Mm-hmm. But the idea is to write it. But we're talking about people who maybe have your back, maybe they don't. Shelby says, what about experienced EMS teaching shortcuts to the student or newbies? Concerns that there are annual changes in regulations and changes in practice, updated equipment, etc. Is this right or not? So let's start with the EMS teaching of shortcuts, because I'm sure if I were teaching, I would probably say, look, here's the book. Bam. Here's how you can actually do it. And it's a lot faster.
Right.
Is that good or bad?
I think it depends on the way it's what it is that you're doing. I think that a shortcut that is hard for us to teach here in the classroom is the scene safe, BSI, number of patients, blah, 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 because it takes about 3 minutes for them to go through that. But once they get out in the field and they start seeing it in application, they're sitting there, they're going like boom, boom, boom. It may take that preceptor like, hey, look, do it at the same time. When you're looking, count the patients, and while you're counting the patients, you're putting your gloves on. You're doing it all at the same time. That's okay. But when it's a shortcut like, oh, don't worry about swabbing the IV site because hardly anybody gets infections anyway. Well, I'm here to say I got an infection. I got phlebitis from a bad IV stick at the hospital that I worked at, and I got a free hospital stay out of it. But it was not fun. And it happens. And if you're wanting to take that chance, because you're not going to find a physician, a nurse, a medic, anybody who's going to sit on a witness stand and say it's okay not to use aseptic technique when starting an IV. And if somebody's telling you that in the back of a truck or somewhere, they're wrong.
Now, I didn't betadine everything, but I always alcohol wiped.
I think alcohol, because I don't think they use betadine anymore now. Anyway.
They did when I was on the truck.
They're using a different stuff now. But yeah, I mean, if you've got it, you should do it. I mean, if that's the way that you were taught to do it, you should. Yeah. It's like, that's stuff that could get you, and that's not really an acceptable shortcut to use. So, but you as a student hopefully would be able to recognize, like, wait a second, everything I read in the book said this, and now he's showing me this. It's not the time or place to argue with him about it. No. Because it's
arguments don't do any good.
Just and just know, like, hey, for me, I'm going to school. I've got to do it this way. I'd rather just be in the habit of doing this because it's the way I'm going to be tested. But just know, go ask your instructor. Talk to your instructor about it, and then.
Or if it's the instructor doing it, ask another instructor, or just trust yourself. Go, I don't feel comfortable doing that. It doesn't mean it's right or wrong. You're not having to pass judgment. I think that's something that new EMTs and students fall into that trap of, well, if I disagree, that's me calling them wrong. And there might be teachers and medics who take that way, and it's not the case. Right. The case is, I don't feel comfortable doing it this way. Now, I did tell a story last week about kicking people off my truck, but that's a whole different thing. I mean, after you do time and time and time, you should get comfortable with things. Honestly, EMTs should be able to put leads on. I don't know where the standing is now, but when I was a paramedic, everything that touched the monitor I was supposed to do. But if you can't put leads, just a basic 3 lead on, why are you in emergency medicine? Because you do learn skills and do things outside. And that's a shortcut that I would take. Is like, hey, you're my EMT. Throw these on for me because I'm prepping this. I'm prepping that.
Or set up this IV bag.
Yeah.
Spike a bag.
Spike a bag for me. Right.
But that's one of those shortcuts too, because I've seen this happen before. Hey, spike a bag for me. They pull out.
They took his food on the ground like a touchdown. I had a medic do that just for fun. Like, here's this bag.
Must be an Alabama fan because they're used to scoring.
Oh!
But anyway, so you say, hey, spike me a bag, and you're busy doing something else, and they grab everything out, and they've got everything set up. You plug it in, turn it on wide open, and you're going down the road, and you notice that there's something wrong with the patient. You look up the bag, and instead of being a 500 bag of saline, it's a 500 bag of lidocaine.
Yeah.
So whose fault is that going to be?
Nobody's, because you're right down. We put in.
No,
that's your fault. It's your responsibility.
That's your responsibility.
Right?
So,
well, technically, I don't know. You're right. I mean, if you're pushing an EMT out of their comfort zone, out of their legal taught zone, there's teaching, there's reality, but there's I never actually let them pick the bag. I would always hand the bag and the kit to them, partially because I hate to be the guy that says, hey, go do this for me, and I expect you to actually go get the chair and bring it to me and fill my coffee. No, it's like, here's all the tools you need. I just need you to set it up. So I actually never ran into that. I do have a shortcut story that ends in a funny experience, but I don't think I can tell it right now.
Okay.
It's one of the, I'll tell it to Tom off there and see what he thinks. Because there's stories you can tell that in person that you don't necessarily put out in the world.
Well, Julie's got a good comment here,
okay,
and I just really want to read it.
All right.
Because I think I think they're dead on here, and says, I think newbies should learn the book way first, and I agree with
absolutely
that. Shortcuts once they really understand the whole process first. And that's what I was talking about. You got to get the foundation first. Get to the foundation,
right,
and then once you have that foundation, and then some experience behind you out in the field, then you can start kind of putting dots together, doing it, finding your way. Because a shortcut, like I was saying, that shortcut that you said, hey, spike me a bag. Okay, you spike the bag and you're busy doing everything. Next thing you know, you done put 250 cc's of lidocaine into a patient. When even if it was a cardiac patient, that's a lot. So you kind of have to be careful. With some of the shortcuts, and you have to make sure, it'd be one thing if that was your EMT partner you've been working with for 5 years, like BK or something, and they know, but somebody who just graduated and has been working 2 or 3 months in the field, they may not know the difference between, because they don't learn what lidocaine is in school. Right. And
they get in a rush, and we're going to get into the ugly habits, which is panic and rushing and those kind of things, the ugly shortcuts. But before we transition to that, again, this is a new medium, it's Facebook Live. We want those thumbs up, share it with your pages. And when it's live, there's a heart there. You can actually, I see on my screen, it doesn't do the full out, but there's happy face, there's shock, there's that. So we can see those if you hit those. And you can do it multiple times, and it's awesome. So please, if you're getting something out of this, definitely hit those buttons, and we appreciate it.
Charles Phillips logged in. He must have heard me talking about him.
He must have heard you. Yeah, he was like, what? There's a disturbance in the force. I need to figure out what's going on.
What's going on?
So ugly habits. I was thinking about what would ugly habits be. Because we've talked about the bad shortcuts. We've talked about how to learn things. And I like to say there's an efficient way to do something as opposed to a shortcut. Because a shortcut is, well, this is the right way, and this is I'm going to go around the right way. And like you were saying, you might get lucky and not have issues ever. And I can't think of anything specific I did, but I'm sure, because of the different waves that we go on, the ups and downs that we have as medics, that I'm sure I've done some bad stuff. And I got lucky that nothing bad came of it.
One is going out and not understanding, is my patient COPD? Are they asthma or is it CHF? Okay, well then let's go ahead and give them albuterol, Atrovent, Lasix, and nitro all together.
Just do a shot,
all the above.
I never do that.
That's a lot
lazy
to do.
Is what that is.
But a lot of people that do that, and that's not, that can be dangerous because it could cause other issues by just giving everything. Now,
doctors do that kind of thing. We're not sure what it is. Let's hit them with a battery of everything.
Yeah, but they're in the hospital.
This is true.
It's just you in the back of the truck.
And they have lots of insurance.
Yeah.
Well, we have $1 million policies.
No, your
typically.
employer does.
Well, that's true. You don't have it. Your employer
Because
has it.
the problem is with that, if you're relying on your employer's insurance, and you are covered under malpractice, but it's not you, it's the employer is, and you are in an umbrella under that. But if it comes down between you being thrown under the bus and the employer being thrown under the bus, they're throwing you under the bus. That's why it is important for you to get your own. And I'm not. This is not a spot for insurance because they're not paying us to do this, and I'm not going to say any insurance names.
Sure.
But you need your own malpractice insurance because you need somebody that's going to protect you.
Somebody's got your best interest. Yeah,
your best interest.
And it's not that expensive. Honestly.
No, it's not.
You're talking about as low as a few bucks, single dollars a month to under $50 a month to have $1 million umbrella policy that says if somebody comes after you directly, then you're covered. And they'll have lawyers a lot of times attached to that insurance that'll come because they don't want to pay the money, so they'd rather have a lawyer go in and defend you and get you cleared of everything than have to pay out the money. So ugly shortcuts, I think, come with panic. Is when we stop focusing on what we need to do as just react. And one of the first, I'm not going to tell the whole call because there's different aspects to it, but I want to talk about the shortcut part of it. The first paramedic serious call I had, I alluded to, I think last week, where there's a T-bone collision at a major intersection in a very busy part of town. And the fire truck was, you can see the station from where the wreck is where the station is. So the fire truck was there. And I was a brand new medic, didn't know anybody. I was scared is not the right word, but I'm going, I feel alone. I mean, I felt like I got thrown to the sharks getting put on the track. I'd been a medic a month, had one heart attack call during that time, which was textbook, went by the numbers, and I'd worked with a partner that I'd known for a long time. I don't know this partner, I don't know this truck, I don't know this area. First day, yay, I get a T-bone wreck with minors. And I think this particular kid was there's a 13-year-old, a 15-year-old who shouldn't have been driving, and then an adult in the other car. And I didn't even have time for scene safety. I didn't have time to survey my patients because the fire truck guys, the firemen, the fire truck guys, because I don't know my terms anymore. The firemen.
You been out that long, Charles? The big red truck,
The door stops, as they were in this case. They come. I mean, I get out of my truck and they come running up with the patient on a backboard. Okay, because I'm at the back of it trying to get a backboard or something. I can't remember exactly what I was doing. I mean, they literally come running. I'm like, okay, we just got in the stretcher. I think they said they were boarding a patient. So all right, we're gonna grab the stretcher, and the patient wasn't buckled to the backboard. They came and they had to stop, and the patient almost slid off the board. Like, oh, didn't even have a C-collar, nothing. That was a very, very ugly, horrible shortcut. It wasn't intentional. Nobody would ever intend to just throw a kid on the backboard, but they reacted, and that was bad. And it went downhill after that. And I wrote, I think, 5 pages of supplemental report on this whole entire call because it went. My part actually went pretty smooth. The flight crew came in, commended me for they didn't know about all the other stuff, but they commended me for the airway and this and that and the other. And I mean, I was in my head, just tons and tons of noise going crazy. But that was bad. Is they panicked or they saw as a kid, and that's what triggered. That had been an adult, they probably been click, 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 move slow. But for them as a kid who wasn't conscious, I think he had agonal respiration. He was breathing to a point, but no C-spine control, no safety on the board, and that's the kind of thing that for newbies especially. I picked on the firefighters because that's who did it in that call. But apparently, I mean, even long-term medics can do this, but newbies especially,
everybody does.
Everything overwhelms you. You have to force yourself to calm down because that's a very bad shortcut.
Slow down, yeah. Everything happens so fast when you're new. Yeah. Everything's coming at you so fast, and a million things is going through your mind. And as you go, the good shortcuts are going to be, oh, I see this, and you go directly to knowing that. But you can't do that without that foundation. You have to have that base knowledge so that whenever you see this, the first thing that comes to your mind is, I should do this.
Right.
Like the kid, agonal respirations. At first, we're a new medic or new EMT, You're going to get there and you're going to look, listen, and feel for breathing. You're going to take your stethoscope out and you're going to listen, and then you're going to think about, should I use a bag valve mask? What should I do? Eventually, after you see that about 3 times, probably, if not maybe even twice, it's going to automatically bag valve, oral airway, bag valve mask, advanced airway. As soon as I can get them to somebody who can place an advanced airway, if I can't. Looks bad, drives fast. We're gonna have to, but
diesel drip.
But even though we say these terms like looks bad, drive fast, diesel drip, rapid assessment, that doesn't mean that you just throw them on the stretcher and haul butt out the door. We still have to do our assessment. We still need to do a head to toe. There's nothing more embarrassing than showing up to the hospital with a semi-conscious or unresponsive patient who you're thinking's either had a stroke or they've got a head injury or something, getting ready to do all this invasive stuff, and the only problem is
oxygen.
They're hypoglycemic.
Oh, okay, there's that too.
Because you took a shortcut. You skipped over that step to get to, all this other stuff to do.
Mm-hmm.
Make sure that you...
Assuming you know what's going on is a very ugly shortcut.
Yes.
Yeah.
Assumptions make an out of you and me. Right?
Yeah.
So you want to know, go through your steps, even though what you can focus on is getting really good at your steps and being efficient at your steps, being efficient at recognizing respiratory compromise, and if I should use a bag valve mask or non-rebreather or an advanced airway or a basic airway, recognizing major bleeding, recognizing shock, being able to see that from across the room. Like whenever you walk into a room, whenever you walk into somebody's house, and after about the second time you've been to a GI bleed's house, whenever you walk through the door, you automatically know GI bleed.
Yeah.
You learn that. That's a shortcut, but that's a good shortcut that you're going to.
Right.
Another good shortcut is woman, childbearing age, lower abdominal pain. It's a ectopic pregnancy till ruled out.
Sure, that's the rule of thumb there.
Yeah. And how big of a shortcut is that? That's
a textbook. That's honestly a textbook shortcut. That's how it's taught. Is
because we can't.
We're
not surgeons in the field, and if it is a surgical emergency, we need to bypass this stuff and get them to a surgeon before they bleed to death. So good shortcuts. Bad shortcuts. Shortcuts can be developed that are good as long as you have that base foundation of knowledge that you can fall back on, and everything stays in line with acceptable practice and standards.
Now, there's a question. I'm not exactly sure how to answer this. What about the shortcut when checking a blood sugar? What is that shortcut?
I don't know if there is a shortcut for doing it. I think that I have a rule that I teach.
All right.
Anybody that has any altered mental status at all
gets
a blood sugar check. If they're shot in the head and they're laying there and they're unresponsive, they get a blood sugar check. And I do that because I'm always
after you stop the bleeding and everything else that you do. Yeah.
Check the blood
sugar.
There's
a process
if you show up and the firefighters are doing CPR on the patient, get a blood sugar check. Because regardless, if they are hypoglycemic for some reason, it needs to be addressed because you're not going to get past a certain point.
Right.
But if you get to the point where you do it on every patient that has it, you won't miss that patient.
Okay. No, I get that. Now, one thing I was taught, I'm not saying it was good, bad, or otherwise. It probably was bad. But one thing I was taught as part of doing blood sugar sticks, and this is part of ongoing education, was do the alcohol wipe and then do it again. But you have to let it dry or you'll get a false stick. I'm like, Jesus, I ain't got time for that. And I'll stick not dirty, obviously dirty fingers, but I'll stick unclean fingers because the risk is so minimal of anything that can go wrong with a blood sugar stick to a finger that as opposed to I have to wait almost a full 60 seconds because you clean it off and you feel so stupid going to somebody else's finger. You're trying to dry it off, right? Which is unhealthy too because you're putting your germs on their alcohol watch. But it's like, oh my! And the only time I ever did it was when I had to actually partner with the instructor, and they're like, "You do it." I'm not doing it. It was just. I hated it.
All a myth about it drying, though. I mean,
that's what we were taught though, at the time. And it may have changed since then. It's been a while since I've done that thing.
Yeah,
that's my only shortcut. Now, when you start a line, if you start a line, you can do a blood test off of that.
You can't, depending on your glucometer.
Okay.
Because you've got some glucometers that are set up that will do venous blood.
Okay.
But some that will only do capillary blood. And apparently there is a difference between the two.
Well, I can see that.
So you have to make sure you check with the manufacturer of your glucometer and make sure you can do it. But usually you are right. Now with the safety needles, I know you've been out for a little while.
No, I had safety needles before we started.
The needles that you have now, it's hard to get the blood out.
Yeah.
Of the needles.
Yeah.
You'd have to, let them bleed a little bit, to get it. But yeah, you're right. Sometimes we do that.
Okay, so little side note. We got a question we're going to get to right before we wrap up here because we're coming down to the end of our time. Again, hit those like buttons, hit the heart buttons, hit the share buttons. Come on, this is an interactive thing. We're answering your questions. We're giving you what you want. Give us what we want. Hit those hearts. So there we go. Somebody hit a heart. I saw it go across. Thank you. But the taping of an IV, which is not what we're talking about today, but I developed, I love those, I think they're called Tega nerves, the patch that you put on. Those were great. But before they came along, they were commonplace. I had a very good method that was shown to me. I didn't make it up, but shown to me where I put tape underneath, fold it down, and then do this strip. And basically ties it in, and it's not going to move. And to this day, I did a good solid almost 2 years of working in a hotel. And actually, my buddy Kelly was watching today. I don't know if he's still watching now. But I showed him this trick, too, because there's loose outlets and loose plugs. That's just like a loose IV. It's like, oh, watch this. I'd take the tape, and I'd show them how to tape an IV, but it's with a plug in the wall. They love that. That stuff works everywhere in your life. You can use that method, which is basically put a sticky side underneath it and then fold it down so it kind of sticks down to the skin, but the sticky side is laying on the plug, right? Mm-hmm. And then you come around with extra pieces and you tape opposite, and it just secures it in. And that works everywhere in life that you need to secure something that can fall out. It is awesome. It is awesome. So here we go. Here is a question that came early on. Chelsea says, do you have any coping mechanisms that help you with the starting trauma of seeing death on a regular basis? So basically, how do you cope with the horrible things that you're going to see when you're starting out in the field? Well,
there's a lot of ways to do it, and there's a lot of ways not to do it.
There's dangerous ways, definitely.
The good way is going out and getting active, talking, having people you can talk to about it.
Yeah.
And a lot of times you can't talk to your family about it because your wife or your husband or your children or your mom, your dad, or whoever it is, significant other, just may not understand. Like whenever we say things, whenever we're talking about trauma, like, what's a good call? Man, I ran a good call. Well, what's a good call?
What's a good call?
I ran this awesome call, man. It was a head-on collision, 8 patients, people scattered everywhere. To us, that's a good call.
Right.
But then what are they doing? They're sitting there shocked, like, oh, my gosh.
How
dare you?
Yeah.
How dare you feel that way?
Sometimes you don't want to talk to somebody initially on that level because they when we start coping, what you're talking about with that good call story is we start coping by kind of describing it like a TV show. Like, here's what we're grabbing the good stuff. Okay, it was crazy, but we did this, and this. We kind of saved the day because that's how our mind grabs. This is what you did good. Mm-hmm. So the other way to do it is to shock and awe, and you crumble under that. But if you tell an average citizen, that story, they're like, oh my God, what are you talking about good? You're talking about 8 people. But no, wait. I saved the day. What? You're so kind of, it takes away that coping mechanism. So you do want to initially talk to somebody who understands what you're trying to express.
Yeah.
For sure.
And somebody has some kind of shared interest there.
Or experience level,
at least.
Yeah.
Or some kind of shared experience so that you can talk about it and get it out. And then eventually you can, those feelings because sometimes you get those feelings of inadequacy, especially if somebody didn't make it. Like, what did I do wrong? And you sit there and you lay down at night and you're like, if I would have only tied my boots faster, or if I wouldn't have went to the bathroom and peed before I went on the call, I could have got there 2 seconds or a minute earlier, and I may have been able to do something different.
Right.
Or if I would have did this or that, and you start what-ifing the call.
Right.
Well, that's when you need to really talk to someone who's been there, because remember what rule number 1 is: people die. Rule number 2, no matter, sometimes we can't change rule number 1, and that's, to me, that's something that you really have to understand in this field. Is that sometimes, despite us doing everything perfect, we're still going to have a negative outcome.
Yeah.
And it's not all about us. We're just there to try to help. We didn't cause the situation. And that doesn't mean we can fix it.
Yeah.
But we try our best to fix it. But whenever we're having those feelings of inadequacy, or we need to talk to someone, being able to just get away and de-stress.
Yeah.
Like, let's go fishing. Let's go to the driving range and hit a golf ball, or something, and just talk about, the call that, these calls we ran and stuff like that is, it's kind of good. And another coping mechanism that I've always had is one that you've kind of said a few times is, you want to be the best. So work at being good so that you don't have all those self-doubts.
Right.
Have that.
Everybody fails. Everybody
messes up.
Yeah.
And, but if you've got like a good foundation and I knew it was a myocardial infarction, I did this, and this, and despite, they still went into cardiac arrest. Mm-hmm. But, it's totally different that if you're sitting in the supervisor's office because you were treating COPD when the patient was having a heart attack.
Yeah.
Why were you giving them Atrovent when they were having a heart attack? Why were you doing this? Well, you got them wrong. Well, then you know what? To prevent that from happening, make sure you know what you're doing. Pay attention. Learn. Sit down in the book. Take your continuing education classes. Network and know people. Talk to people. When you do have these feelings and things do go wrong, be able to have someone that you can talk to. And if you can't find somebody to talk to, well, then reach out to a professional.
Yeah, and we're here. I mean, we're going to do the show we're looking at every Thursday around 2:30 p.m. And you can shoot your experiences. I mean, one of the things we'll come up with is, what do you need to talk about? And you'll have a week to start messaging us and those things. And we'll share our stories. And we're going to, I know, I don't want to speak for you, but I know you're on the same train. Mm-hmm. I'll be brutally honest about the mistakes I made, and the doubts I had, and the horrible times and the good times. And
I still have a license.
Well, I don't. So I have nothing to lose on that one. But one of the things that actually helped me is I was typically not a smoker. I have smoked at different times through life, mostly because of outside influence. I smoked a little bit through EMT school. I would bum cigarettes sometimes as a medic. Because every once in a while there's that de-stress. But a lot of medical people smoke because it is a natural de-stressor. But what I loved was hanging out at the smoking table. Every EMS base everywhere has a smoking table. Because you want to sit around. You can't smoke inside the station. Sometimes you have to be a certain distance off the property, even depending on where you are. But there's a table. And that's where I'd go and hang out all the time. Because you got to learn to laugh. That's my advice. Is honestly, that's a huge de-stressor, is laughing about things. And you have a dark sense of humor, and you'll develop a dark sense of humor. And learn that it's okay, because you're not making fun of a real person. Right? You're not actually going, oh, this person, and you're mocking them. What you're doing is taking away the heaviness and the gravity of the situation one step at a time by making jokes at the expense of this thing that you would actually never do about a real person. So you're dehumanizing them a little bit, which you have to be careful with. But what you're really doing is de-stressing, taking some of that pressure off, so then maybe you can talk about it. I think tabletop is the number one source for curing all of this stuff, for helping with this, for preparing you. And what that is when you sit around and you work out a call with no blame, and with people who are there and people who weren't there, who weren't biased by the situation. And the second that somebody blames, oh, why'd you do this, or calls you a dumbass or something, they got to go. Because what the whole point of the tabletop is, nobody's wrong. How can we do it better? Or let us confer and say, yeah, you did it great. Because you'll have your doubts. Could I have done something else? And if you tabletop it, you just get the call out with people you trust. You start going, okay, the call came in, this and that and the other. And you have to be honest. You have to be safe, feel safe to be able to express everything. But if you go through it, what you'll find is, okay, so next time, now it's in my brain, because experience hardens learning. It cements it in. And so you had this experience, and then you add the learning to it. Talk it out. Next time I can try this. Next time I can think about that. Or, well, no, I really did everything, and that makes me feel better. And Julie says, don't hold it in. It is okay to cry. Absolutely. Yeah. It's okay to cry.
Exactly. But also, too, don't be afraid to take your medicine. Because if you did mess up, be own up to it. When you're there at the because you remember whenever I was a captain and you worked for us over at Newton, I did dinners. I don't smoke. I don't hang out around the smoke because it bothers my lungs.
Sure.
So
and that is something. Yeah.
We did dinners and we talked and we sat around the day room and talked and if you did something wrong, be willing to listen to the people that have experience and learn from it. But if you're the guy with experience, don't be overly harsh.
True. Yeah.
If you're over, when somebody's being overly harsh, that needs to stop. But if if you're giving your examples and it's like, really, well, and it's obvious that, maybe this could have been done a little different or whatever, as long as that's being presented in a respectful manner, you need to be able to absorb it and then take that information and put it into practice later so that you can learn from it.
Case in point, and think about how we're going to wrap up. We're about done here. We're at a little over an hour. But case in point is I told a call last week where I drove. I was paying. I was the driver. I can't get you to the hospital. I was slamming sideways and hitting the brakes and going too fast. And two medics in the back of that truck, and they were getting thrown around. Actually, it might have been three medics. I don't remember. But they were getting thrown around. And they yelled at me. One of them stuck their head up, as you have to do sometimes, stuck their head through the window going, slow down, stop, or I'm going to punch you in the face.
Right.
Because I'm punching them in the face with the truck. And But here's what happened at the end of it. After they went in to take care of the patient, I'm outside. One medic comes up, and all she did was rip me a new one. And I already knew I'd messed up. I already felt bad about everything. I didn't realize what I was doing. I was new. I needed training. And I panicked. And, she ripped me up one side and down the other. We were never friends. She had it out for me after that. She tried to get rid of me, and she won. She got rid of me. She got me out of that job. Didn't do any good to the situation. Didn't do any good for any medics coming forward. Didn't make any positive change on anything. It just made me feel like crap. I didn't know how to fix what I did wrong. I just knew I did wrong. And ultimately, because she held that grudge, I lost my job there, and she got nothing out of it.
Right.
Another medic in the back of the truck came up after she did, said, don't worry about her. She's right, and we need to calm you down, but here's what you do. And he taught me about how to calm down, gave me the picture of, think about it. You're only you're tunnel visioning on the cars in front of you, but you got to remember you've got human bodies in the back and blah, 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 blah. And he made a huge change to where it changed my driving patterns from then on out 100% changed. And that's what you're talking about, the good versus the bad. If all you ever do is yell at somebody, they won't know how to change. But if you tell them it's okay.
Once you start yelling, that brick wall goes up.
Exactly. It just rips into them. So, all right, I think Julie says we RNs table talk all the time as a coping mechanism, and that's
great.
That is
because there's so much you can learn from it, and you have to be able to take every situation and learn, because you take that forward and apply that to the next. That's another tool that you put in that toolbox. That can make an outcome positive in the future for someone else. And you know what? We don't have all the answers.
Right.
No one has all the answers, but collectively we get together and we can come up with an answer.
Yeah, absolutely. So, until next week, tell them about the Facebook page and the website.
Yeah. Come on over and check us out at Georgia Institute of EMS on our Facebook page. Come to GeorgiaEMT.com. That's Georgia all spelled out. EMT.com. We have some classes coming up at the end of the month. We've got an EMT class starting the end of September for those of you who want to come on board and jump on the bandwagon with us, become an EMT. We can get you knocked out in as little as 8 months, and then we can bring you on forward to advanced EMT. We've got some advanced EMT classes starting in October that will be updated on the website here soon. Just give us a shout out once again, GeorgiaEMT.com.
There you go. And I'm Charles McFall. You can find all my shows at charlesmcfall.com. You can follow me on Facebook. It's all linked through charlesmcfall.com. And we're going to do this show every week. We're going to come up with a new theme every week, a new overarching topic, but we want your questions. We want your responses. We need your interaction. And again, new medium. So hit us with the hearts, hit us with the happy faces, hit us with the likes. Share it around. This is going to go on YouTube. What's the YouTube channel?
Georgia Institute of EMS.
Georgia Institute of EMS. And, of course, like and follow this page so that you will know when this show is live. And we actually are trying to make this, we're going to try to tool this into continuing education.
Yep.
So that, because this is an official school, Georgia Institute of EMS, and if we can get any of if you have questions, what's the email? So they can possibly get their institute to accept this as continuing education.
Info at GAIEMS.com.
There you go. And I actually meant to text you to see if you wanted to make one email just for the show, but we'll talk about that.
Yep. We'll do that.
So there you go. Until next week.
Yep. Next week, Thursday, 2:30. We'll see you then.
That's Tom. I'm Charles, and we'll be around.